Rethinking the role of race in lung function, the shift to race-neutral spirometry interpretation. Normative values for lung function have traditionally been determined by age, sex, height, and self-reported race. The inclusion of race has become increasingly controversial, as it implies that the observed differences in lung function among individuals of different races are solely due to genetic factors. Okay, let's look here for a second. So, normative values for lung function are what the lung values should be, or in other words, they are the values that have been found in healthy individuals with normal functioning lungs. Although hereditary factors may play some role, lung function is influenced by numerous environmental factors, such as access to prenatal care, smoke exposure, both direct and secondhand, childhood infections, nutrition, and ambient air quality. These factors, many linked to social determinants of health, likely play a larger role in the observed differences in lung function between races than ancestral origin. Conflating race, a predominantly social construct with inherent biological differences, has been increasingly recognized as a fundamentally flawed approach to pulmonary function test interpretation. Spurred by these discussions, and with a clear agenda to reduce racial bias in pulmonary function test interpretation, the American Thoracic Society recommended the worldwide adoption of a race-neutral set of spirometry reference equations in pulmonary function laboratories in 2023. In this article, we outline the complexities associated with this recommendation and the resulting impact on spirometry interpretation and patient care. Okay, two other notes. So pulmonary function, that just means lung function. And then reference equations. These are explained in the video posted on Canvas, although there the woman calls them reference values. When someone takes a spirometry test, the values produced by the test are the amount of air that the person can exhale, specifically the total amount exhaled and the amount exhaled in 1 second. These values will obviously be different for a short woman and a tall man, as well as for a 20-year-old and a 65-year-old. So the reference equations are used to determine what's normal for men and women of every age and height, plus for each of the 4 races that are described in the next column, this column here. Okay, so let's get to that. What does race-neutral spirometry mean? Mayo Clinic and many other pulmonary function laboratories internationally currently employ the Global Lung Function Initiative GLI 2012 multi-ethnic spirometry reference equations. So I think later, down here, so GLI 2012 is referring to these set of reference values. These equations provide normative values for 4 ancestral origin categories: white, black, including African American; Northeast Asian, including individuals from Korea and China; Southeast Asian, including individuals from Thailand, Taiwan, and China, southern China. For patients who do not self-identify in these 4 categories, GLI investigators have recommended the use of other/mixed reference equations, which represent an average of the equations for the other 4 categories. The race composite GLI other equations, this one referred to just here, the race composite GLI other equations have been proposed as a race-neutral option, but faced criticism due to the white predominance in the database used to develop these reference values. In response, GLI global equations were recently created by assigning different weights to each of the 4 ancestral origin categories to ensure that the final equations represented an equal distribution from all 4 categories. Okay, so this note here is leaving aside the issue with race, figuring out what should count as normal lung functioning still takes some work because a lot of data is needed, namely lung function values for people of both sexes, all ages, and all heights to determine what is normal. The GLI global reference equations were created by essentially taking all of the data that had been collected for this purpose and averaging it for each age, height, and both sexes, and leaving race out of it. So we simulated, that is the authors of this article, the impact of transitioning from GLI 2012 multi-ethnic to race-neutral GLI global equations on spirometry interpretation in more than 100,000 Mayo Clinic patients. Using GLI global changed spirometry interpretation in 10% of patients with the greatest change seen among Black and Southeast Asian individuals. The most common change was the increased frequency of prism, defined as a reduced forced expiratory volume in the first second and or forced vital capacity with a normal ratio of the two. Further testing with lung volume measurements is recommended in this setting to determine whether these findings are due to a restrictive process or occult obstruction. Oops. Okay, so then the next note. In this is the study that they did. They used the results from spirometry tests that had previously been done just for normal clinical reasons at the Mayo Clinic. All of these spirometry tests had been interpreted when they were given using the GLI 2012 equations, which included race as one of the factors. Kanji and his colleagues, that is the authors of this article, reinterpreted the data using the GLI global reference equations, which didn't include race as a factor, just age, sex, and height. Okay. And here, this is a preserved ratio impaired spirometry. The ratio is the ratio between first the amount of air exhaled in 1 second, and then second the total amount of air exhaled in one breath. Prism occurs when the ratio between these two measures is normal, but one or both of these values is too low. Okay, so for our purposes, all that we really need to know is that this diagnostic test measures how much air can be exhaled in one breath. This then indicates lung capacity. So these are the two tests: exhaled in 1 second, exhaled in one breath. Obstructive in this context means that the person cannot exhale all the air in his or her lungs. Restrictive means not being able to fully expand one's lungs with air. There are obstructive lung diseases, asthma, cystic fibrosis, and restrictive lung diseases, for example, pulmonary fibrosis. The spirometry test is just the first diagnostic test, and then further testing is required to determine the specific cause of lung health problems. Okay, so this is what we're about to get to, but the note is you should read this, but don't worry too much about what's inside this box. More important is the rest of this paragraph. Okay, so although transitioning to a race-neutral approach does not change the frequency of obstruction in Black individuals, GLI global does result in a reduction in percentage predicted FEV1 in these patients. In practice, this reduction translates into increased severity grading of airflow obstruction in Black patients. 2 recent studies have suggested that about 20% of Black patients would be impacted, with the most common change being a reclassification from mild to moderate obstruction. Table 1 provides a summary of other changes in lung function interpretation resulting from the use of a race-neutral approach. So that's this table here. Changes in lung function interpretation resulting from the use of GLI global for each of the 4 categories, percentage of people affected, and then severity of impairment of lung function when we use the new values is increased, decreased, decreased, and increased. The impact of a race-neutral approach on patients and patient care. Race adjustment in spirometry testing normalizes the lower mean observed lung function in certain racial ethnic groups, including Black and Southeast Asian individuals. This factor can lead to underdiagnosis of lung disease and may contribute to health inequities. Benefits of adopting a race-neutral approach. An important benefit of adopting a race-neutral approach is the potential for earlier diagnosis of pulmonary disease in underrepresented populations. For example, adoption of a race-neutral reference equations in Black children led to a doubling in the number of diagnoses of uncontrolled asthma. Earlier diagnosis and assessment of greater disease severity should in turn lead to earlier initiation and appropriate escalation of treatment for such patients. Similarly, the increased identification of PRISM may lead to earlier diagnosis of restrictive lung disease, such as pulmonary fibrosis. A race-neutral approach also stands to benefit underrepresented populations by qualifying them earlier for specific treatments that rely on predicted lung function thresholds, such as non-invasive ventilation for neuromuscular disease or pulmonary rehabilitation for chronic obstructive pulmonary disease. When compared with standard multi-ethnic equations, the use of race-neutral equations has led to higher lung allocation scores for Black patients, potentially increasing their priority for lung transplants. Okay, lung allocation scores. Here, this is a score that is used to prioritize people who are waiting for lung transplants. It combines the urgency of the patient's need with the patient's likelihood of survival after the transplant. The transition to a race-neutral approach may also allow members of underrepresented groups to qualify more readily for disability compensation that relies on impairment assessments that use % predicted lung function as cutoffs.